we've had a very rich panel discussion. We did start about 10 minutes late, so I think we can take the indulgence of organizers to have a few questions or comments. But keep them crisp and concise. Veena, go ahead.
Okay. Veena Varghese, health economist, PhD 5. Great panel. Yeah. Just an extension of thought of what Professor Hanson, Professor Sen, and Professor Ravindran said, transferring knowledge to implementation. And that is what I think health system research is all about. And thinking of two policies in India that recently has led to, as Gita said, the increase in institutional delivery. One was the JSY, the Janani Suraksha Yojana. It's a demand-side incentive that was put by the government to improve institutional deliveries. Now, I think either one of you mentioned about the need for supply-side strengthening. Now, did that happen before JSY was started in India? And if the supply-side strengthening had happened, would we have had a better quality care? We do have increased numbers of institutional delivery. Has it really led to reduction in MMR? The question that Gita has been asking. And we don't know the answer to that. Has it really led to reduction in MMR? And the supply-side strengthening hasn't happened. Another very good policy that came up in 2011 is JSSK, it is the Janani Shishu Suraksha Karyakram. Under that, the idea is that if we would improve access, moving towards universal health care by reducing all cost barriers. All diagnostics, all drugs have to be provided free. Now, without looking into the monitoring aspect of it, having just a policy which says women should access and women should get free drugs, women should get free diagnostics. There was a recent study that we looked at where are women actually getting free drugs and free diagnostics? And the answer is no. Because there is nobody monitoring the system to see whether the drugs are there, are diagnostics available in the center, are there practitioners who are able to diagnose women available in the center. So having great policies without the supporting structure and supporting monitoring mechanisms makes it very difficult. And I think India is a land of really good policies, but not always transferred and translated into action. One small comment on the evaluation aspect. I think one of the earlier speakers talked about, and a few other speakers talked about how important it is. And I was thinking, using the term evaluation, I think the WR from WHO said sort of leads to a feeling that, oh my God, somebody is coming to evaluate you and it's a bad idea. So moving from that, and we did one of our research where we called it assessing and supporting. So it is no longer the term evaluation used, it's actually to assess what's happening and to support the intervention to make things better. So that sort of thinking of internally trying to evaluate, or if it's an external evaluation, then it is more for assessing and supporting. Thank you.
We'll take questions from people who have not already asked. Okay, you already have the mic.
I'm Dr. Shailesh Jagtap from JSI. Throughout this panel discussion, just a few things that came out into my mind. That there is an integration between the researchers and the implementers. What is happening is implementers are thinking in terms of only implementation, researchers into the research part. And until unless these research and implement come together and generate the right question will not be come directly into the researcher's mind or into implement. And if they come together and develop the right questions, then only the health systems research.
I think you make a very good point on demand responsive research and how the research community must respond much more actively to the actual fresh needs of the policymakers or the decision makers. The policymakers and health system managers are also important in decision making. That point is well made.
Second point related to when we talk about HPSR, we first we talk about the policies and then systems. So maybe initially we can talk health system. So I think health system should start with the districts. There was a decentralization discussion, also decentralization. So I think the system research house should start from the district level, and then maybe we can have a good policy level research.
Sure.
I'd just like to sort of get a clearer understanding of what health policy and systems research actually means. So it is a question coming from that perspective. So I think it's clear, the way Dr. Devadasan put it, that in a system, when one thing is there, it affects another. And that is usually the case when it's a closed system. Now, what I'm trying to sort of understand is to what extent health policy and systems research would go beyond a particular, or how open it is. I mean, it's clear that it can't really encapsulate everything related to social determinants of health. That would be just widening the system too much. But what about immediate determinants like nutrition and water sanitation? What is the kind of scope within that research? And if so, then how can that be sort of brought in and connected with health policy?
I think, well, I'll let the experts answer, but most people, I think, believe that health systems research should not be confused just with health services research. That some of the social determinants which have a close interaction with health are also important for study and analysis.
Namaskar, I am Amitabh Sarkar, doing PhD at CSMC JNU. As we are discussing on HPSR and its input on USC, so I have one theoretical concern before going for empirical understanding. That what model of welfare we follow in India? Is it a right-based or need-based? Certainly not right-based. So we are not following the Bavarian model or Bismarckian model here. So this need-based model like NRJ, RSBY, JS1. So then the concern is, as quoting Manager Anderson, felt need or epidemiological need, the expert need, or the provider's perspective. So these three come together. Then the provider perspective or the role of the state will actually apply that what kind of services, who will get the service, who will not the service. So there's application of service inclusion and service exclusion. So as we are talking about HPSR, so these structural determinants, as certainly she has covered that society elements of few of them. So I think that with this HPSR, we should address first these structural determinants. Then it must be, it must be easier actually to go for that demand side financing, conditional cash transfer, or rather the macroeconomic, other macroeconomic determinants. Thank you.
I would just like the panel to reflect, the ones who follow the news in India, on Samir and Nandi's article on widespread sort of corruption in the health system, both private and public. And I want to link that to the question of medical education. So if we are talking about health systems, and I think a lack of human resources is critical, we are drawing on our English doctors and all, because we seriously lack, trained allopathic doctors in rural areas. But also I would say there's a looming crisis in urban areas. And so the Medical Council of India, ICMR, there's a lot of sanctioning, accreditation of institutions who then produce suboptimal cadres of, So could the panel, the ones following the Indian setup, reflect a bit on this in the context of, Thailand? We've spoken a lot about Thailand, but supply side strengthening and values. Panelists spoke about values and, Hippocratic oath and so.
I think we have had quite a few questions for the panelists to digest. We will take the last question, and there were very brief comments back from the panelists on any of the specific issues they'd like to address. You have been struggling with the mic, I think.
The mic in my hand. I have a small comment. See, Indian Federation, I think health belongs to the state subject. So I think considering the universalization, I think we need to consider that as well. Because whatever with the policy and the research we are talking, and when we are talking about the universalizations, we have to consider that as well. That is the small comment. And that leading towards the two elements of it. One is the research capability. So I was thinking of the research, health research, especially in Bihar. I don't see any institution. So maybe the researchers here or institutions sitting here, they may think about the regional balance in terms of the health research, because there is no any institution I can see today is there in those kind of areas. And third thing on the system, I was analyzing the data of DLHS and NFHS for last 3-4 DLHS and NFHS, and I found that all the PNC and ANC data all are coming down for UP. it's for UP policy, population policy, we are doing some work. So again, it depends on the state when all resources are there, but the performance and health delivery system is very good. So that was I wanted to bring for your reference.
Okay, I think since you have the mic, please go ahead.
This question is addressed to just the chair of this panel. I know you are expecting the health policy and system research to contribute to delivering the universal health coverage, but in a country of our size and our problems, what's the size of the HPSR community? What is the size? And do you think that size can deliver what you are expecting it to deliver?
Well, I will take Devadasan's help for this. But I think the question here is, if a research community such as the HPSR community can be catalytic in initiating fresh thinking, policy critiques, designing interventions, evaluating them, and studying them along, and providing that information on a continuous basis to the decision makers and the implementers, I think it will be a signal service. I don't think this community is expected to perform all the functions of implementation and execution. I think, therefore, that is where the difference lies.
I'm going to be provocative here. There was a recent article in the Lancet about research waste, and says how 45% of research is researching already things that we know. We don't have to again research them and find answers to. So I think instead of looking at us, out there, we have to look at ourselves and say, are we doing the right research? And there's so much, I think all the panelists have said, there's so much of research to be done. The question is, are we doing the right research, or are we just in our comfort zone and looking at hemoglobin levels, prevalence in my backyard? So that is something else.
No, the practical reality is that more policy is probably made or shaped by the converse of those people sitting in IIC. The intellectuals sitting in IIC do have some influence. The converse, the CII, may have more influence. But let's change the equation.
I think this question of the size of and the contribution of the HPSR communities is something that we need to reflect on and have a strategy to develop in a very conscious manner. So this little platform is one small way, but there are many institutions across the country that are actually developing research capacities through a variety of ways and setting up. One is the Masters in Public Health programs, the PhD programs, etc. But even in civil society, there's an effort to strengthen research capacity. And there are networks that are forming and getting people from sub-district levels, to engage in such processes. I think the governance of research, or the research governance and research planning, is something that needs attention. And just 1% of the budget is sort of not sufficient for this. One needs to have maybe a task force that develops, it works with the secretary, multi-sectoral sort of task force that can actually plan for this, have a 5-year, 10-year, short-term and intermediate and long-term plan.
Okay, I think we're getting very animated here.
I'm a medical doctor. I've just moved to the field of public health about a year back. I'm doing MPS with Johns Hopkins. So I was just wondering that we are talking of health policy and systems research and basically talking of two dimensions. One is of researchers, one is of policymakers. How much are we integrating the medical fraternity into this whole process? Are they our active contributors in decision making? Because I feel there is a bit of a gap out there. Maybe we don't have them over here. I don't think we really have any practitioners. Do we take their inputs when we are going in for all this?
I think there are practitioners in the overall community of health systems and policy research, but by and large, unfortunately, what has happened in India is that most of the medical profession has not been interested in this type of research. If at all, a bit of descriptive clinical research or occasionally epidemiological research. but not in terms of policy and systems research. There are notable exceptions. It's happening. But I take your point entirely that we ought to draw them into this broader discourse.
Because they didn't have the right illumination exactly because that's what
many people sitting here at this table are reformed clinicians. But anyway, I will certainly take your point.
No, but actually we are, I think they do play an important role, and since the issue of corruption came up earlier, I'd just like to mention that there's a process, going on, and there's going to be a National Bioethics Conference in December in Bangalore, where we expect about 600 people, multidisciplinary, including medical students, nursing students, and there's a pre-conference workshop on developing an integrated teaching program for ethics, bioethics, and health system related ethics, public health ethics, to develop teaching programs which will be widespread. There are, as you know, there are networks of medical colleges that now work, and so through these networks we are also trying to reach that community. I mean, it's not an untouchable community, they have a role.
Most of them are actually in the nature of comments or suggestions, and I'm sure the discussion will flow out. And the idea of creating a platform is essentially to provide an opportunity for that kind of discussion, but also to ensure that we can all act in concert together at the level of multiple institutions and agencies, but also as a coalition of people interested in HPSR to advance the field for a purpose of transforming India's health system and the social determinants alongside, so that we can achieve better health. And that would ultimately be the vision of UHC. And therefore, if we are actually going to be creating this platform and this whole network, the net worth of that network will be decided upon how we advance UHC. And that, I hope, is something that we will be able to do collectively together. So thank you very much.
Thank you, Dr. Reddy.